Hi, I'm Dr. Ushma Bhojani, Women's Health Physiotherapist, Clinical Instructor for Invasive Pelvic Floor Rehabilitation for WOW IIPRE. Vaginismus is commonly seen condition in female sexual dysfunction. Sadly, it being rarely spoken about makes it difficult for the suffering patients to reach to a clinician or a practitioner who could help. The need of this study is to create awareness about vaginismus and the role physiotherapy plays in management of female sexual dysfunctions. Vaginismus is a condition that can be defined as uncontrolled contraction of the vaginal muscles during an attempt to penetrate a finger, tampon, or a penis. Such patients come with a complaint of inability to achieve penile penetration during sexual activity. Today, I am going to share a similar case. A 39-year-old woman, Nelly Perez, an engineer, was referred to us with no medical history. Her chief complaint was severe pain during attempt for sexual penetration, leading to coital inability. She had been married for 13 years and it was a love marriage with a 3 years of courtship period. No history of abuse or any other medical or surgical history. Had visited multiple gynecologists in past and had developed an apprehension to assessment because of no productive outcomes. Before any kind of assessment, she was counseled and explained basic anatomy and physiology of male and female genitalia and pelvic floor muscles. Once she was comfortable, a written consent was taken and a comprehensive assessment including postural assessment, perineal observation and invasive pelvic floor assessment was done. She had kyphotic posture, tight adductors and little apprehension to internal assessment. On Haig's MMT scale, she was at -1, which is inability to penetrate a finger. Oxford scale was not used as it does not define relaxation of the muscle. On dynamic assessment, we could see a lot of accessory muscle use. When we made her cough, the perineal movement was inwards. On palpation, there was a lot of tenderness around the mons, labia majora as well as the labia minora. At the first session, we could not penetrate our finger, but a comfortable tenderness assessment was done. With regards to her endurance, she could hold the contraction for 5 seconds for comfortable 4 repetitions. Her female sexual dysfunction scale scoring was around 24 out of 50. Post-treatment, on discharge, there was no use of accessory muscles, no tenderness at the perineum, and her Haig's MMT scale was -3, which is comfortable 1 finger penetration. With respect to dilators, now she was able to insert size 5 of dilator comfortably. She was able to hold her pelvic floor contractions for 8 seconds and 7 repetitions. Her female sexual dysfunction score was now 46 out of 50 and she was able to achieve a pain-free and a comfortable coital activity. The pelvic floor therapy interventions used to treat her included relaxation techniques, perineal massage, transvaginal trigger point release with Weiss-Anderson's techniques, sweet spot release, and use of pelvic floor 360 with Glazer's protocol for relaxation. And dilator training was given for functional rehabilitation. Once she was comfortable with the dilator of size 5, functional training was also given. Eventually, one couples counseling session was done just before the discharge to guide them for the coital activity and to clear out any doubts or apprehensions. The outcome of the physiotherapy treatment was that it helped in reducing the pelvic floor muscle tone, release the trigger points and reduce the anxiety and fear of the couple for penetrative activity, resulting in a pain-free and apprehension-free coital activity.